Good morning, everybody.
Morning.
Good morning. Thank you so much for coming in on a Saturday. I know working an extra day during your already full week is not exactly desirable, and I hope you get a lot out of this conference this weekend. We've been doing this conference since 2010, when the first hybrid, or the new hybrid, had opened for Fondre Noir, and it just keeps getting better and more formal every time. And I hope you take away, God bless you. I hope you take away information that improves your practice and ultimately improves patient safety and helps these guys out a lot more, because we'll be better prepared. I'm going to talk a little bit about the agenda. This is in your folder, and I'll talk about some of the papers that are in your folder. So 7:30 to 8-ish, we did breakfast and everybody signed in, and there was a couple people who missed a spot or two on the form, and but I'll get with you later and finish filling that piece in. From about 8 till noonish, we're going to have a series of lectures. You'll see on your agenda there is not specific break times built in, but as you need to, feel free to come and go. The restrooms are right out here past this boardroom, and lunch will be served similar out here, but then we have the tables in the next room to eat on. After lunch, we will completely leave this floor, and we'll transition up to the 5th floor, which is Mighty, and then that will be the map at the bottom of your paper there. There are 4 rotations that are included in your CEU part of the day. So they're 4 30-minute rotations. You will spend 30 minutes in each of those places, and that will get you the final piece of your CEU requirements. So you can see on the map, and there's a larger copy here, where each of those stations are. Then after we're done with that, then we'll transition to the green area. So we won't be in the green area until we get through all this other piece. I have to keep the CEU piece of it and the rest of it completely separate. So then we'll transition to the green area, where you're free to stay as long as you need to at each individual station. Go to the stations that you feel like you need more time. That's really the flexibility of the way this agenda is built. Any questions about that? Okay. So to start the day, we have Dr. Bismuth. Dr. Jean Bismuth is an associate professor of cardiothoracic and cardiovascular surgery at Houston Methodist Hospital in Houston, Texas. He received his medical degree from Copenhagen University in Copenhagen, Denmark, and completed his surgical residency at the Brooklyn Hospital Center. And subsequently, he completed his vascular fellowship at Baylor College of Medicine in Houston. His clinical interests include the treatment of patients with aortic disease, carotid disease, mesenteric disease, venous, and lower extremity occlusive disease. He also has expertise in dialysis access and arterial and venous malformations. As a recipient of the Dyer Fellowship Award, Dr. Bismuth has focused his research interests on vascular surgery robotics, imaging, and computational fluid dynamics. Another major area of interest includes vascular surgical training and simulation development. Dr. Bismuth's other research interests include the pathogenesis of atherosclerosis, preventive and medical interventions in vascular surgery. He's a member of a number of societies, including the Society for Vascular Surgery, American College of Surgeons, American Medical Association, the Michael DeBakey International Surgical Society, the Danish Medical Association, and Peripheral Vascular Surgical Society. Please help me in welcoming Dr. Bismuth.
Thank you, Jen. Let me see if this is on. It's on now. So obviously I'm not Dr. Lumsden. I was supposed to give his first talk. He is somewhere between Barcelona and south of France. A much preferable place to hear, I'm sure. But nonetheless, I hope I give you guys some insight to different things. Before I get started, maybe you guys have questions about, he was supposed to talk about, kind of get you guys excited about the hybrid OR and so on. Are there any questions as far as like kind of where things are going and what we have in the rooms that maybe you guys haven't been exposed to as much. Some of you who have dealt with the robot, I know in the hybrid OR, I think kind of find it to be a little bit of a pain. That robot's actually going away completely. And the next robot is going to be have much less of a footprint on the space. That's probably going to happen within the next year or so. That Hansen Medical company was bought by actually the original founder of the company, and they have this pretty neat little device that's going to be removable, a lot less invasive. So instead of talking about the robot, it'll maybe have a more pleasant name. But, so I don't know if anybody has any questions before I get started about kind of the whole hybrid future. If not, then I'll just start on my talk. I have a lot of things to talk about. Some of it is going to be maybe a lot of repetition for you guys around the, Jen wanted me to talk a little bit around the pathology and kind of how we deal with aneurysms. All of you who have been at least in the Fondren OR know quite a bit about aneurysms from some of you who have been way back here since even maybe Crawford and the likes, and then through Caselli and of course now with us. And that's obviously, you've seen a lot of changes in the way we treat things. But I'd say there's no perfect way yet. Even in what we do, there are a ton of complications. You guys probably don't see them all in the operating room. But there are some real pitfalls in what we do, and it's far from perfect, both from our standpoint as far as being exposed to sometimes long hours of radiation, which is always something we're concerned about. One of the pioneers of fenestrated endografts in this country died of abdominal cancer about 2 years ago. And he started in the heyday when radiation wasn't as safe as it is today. We didn't know how to protect ourselves as well. But he died a fairly young man, actually, around 48, 49. So it's definitely something we're concerned about, whether it's protecting your eyes, your thyroid, and everything else, and particularly for the young ones in here who would like to have children in the future. Protect yourself. You know, Cassidy, for those of you who remember, Cassidy was one of our residents. She was pregnant and wore two leads throughout her pregnancy and had otherwise normal pregnancy and everything else, and thankfully a very beautiful child. So anyways, what I'm going to talk to you guys about is aortic aneurysms and what I think you need to know. Probably there's too much, and I may jump over some of the slides if I start seeing some of you falling asleep, plus it's early in the morning here. Any case, so you know that aneurysms can happen pretty much everywhere. Some of them we preferentially deal with from an endovascular standpoint, and that would be some of the things like these visceral aneurysms. You guys have probably seen us embolize some of these splenic aneurysms, and those are really much easier to get at from an endovascular standpoint and pretty straightforward. If you look at some of the ascending aneurysms today, we don't really have any good endovascular tools, so that remains an open treatment. The descending aneurysms, obviously, these are some that we treat pretty easily with stent grafts. This is just a one-piece stent graft, and that goes pretty quickly. Popliteal aneurysms, traditionally they've always been treated open, and sometimes we still do that if there aren't any really good options, and particularly if the popliteal aneurysm is already thrombosed, then we'll usually bypass it. But the infrarenal aorta is really the most common location for aneurysms, and that really has to do with kind of what the tissues are like in the aorta at birth. So up in the chest, you have more elastin, which allows for the distensibility and the contractility of the aorta. As you go down towards the bifurcation, there's less and less of that tissue, and so hence we have a lot more aneurysms in the abdomen. And what's the definition of an aneurysm? Dilation to more than 1.5 times the size of the normal aorta, or any vessel for that matter. So if you have an iliac vessel, it's supposed to be 9 millimeters. 1.5 times that equals an aneurysm. So for thoracic aortic aneurysms, we say for the descending, if it's greater than 5.5, that's something we would treat. Now we'll talk a little about aortic dissections, which are a tear in the intimal layer of the aortic wall. Everybody understands what that means. Basically, the aortic wall has 3 layers. There is the intima, the media, and then the adventitia. If the intima tears, then basically what happens is blood flows down between the intima and the adventitia in the media and creates that tear. And then, of course, AAAs. We kind of talked about that. Okay. What is the scope of the problem? Well, it's actually not insignificant. So it's the 13th leading cause of death in this country. Approximately 100,000 cases are diagnosed annually. But that underestimates the actual number because, remember, about 80% of people who rupture never come to the hospital, and most of those have never had a diagnosis of a AAA. So the number is probably quite unknown and underestimated, but it's still pretty significant. About 15,000 deaths estimated per year. The prevalence is 4 to 9% in males greater than 60 years of age. And so, there was a huge battle a few years back to try and get Medicare to pay for a screening. So when you initially enter into Medicare, there's a package for men only to get screened by ultrasound. I see Becky shaking her head, but
I'm not quite there.
yeah. But it's because there's a lower prevalence in females, significantly lower prevalence in females, and so they don't feel that the yield would be as valuable as it is in men. We consider them aneurysms when they're greater than 4 centimeters in the aorta, and that goes to the prior definition. And you see it in 1% of men between 55 and 64, and 2 to 4% increase per decade. The cost is not insignificant, and I think when you look at some of the devices I'm going to show you later, what you'll see is that cost is likely going to go up. But that cost includes not only devices, it includes hospital costs. So when Caselli does all his operations, he's one of the best surgeons I've ever seen. But a lot of them go to sniff, as you probably know. They get trachs, they get lines, they get pegs, and they go to sniff. And that costs the healthcare system quite a bit of money. So if we look at kind of some of the numbers, I want to try and go through some of these a little faster, but essentially just looking at male ruptures, all ruptures versus female ruptures, you can see that there's a huge difference between females and males. Here you have males on the upper curve and females on the lower curve. So females tend to rupture a lot less than men. As I said earlier, a lot of patients come in or die ruptured having never known that they had an aneurysm. And that's because most of them are asymptomatic. 1 in 3 aneurysms will rupture. Most patients with rupture are unaware that they have an aneurysm. So it really goes to kind of the importance of screening, particularly in men, so diagnosis prior to rupture. Having said that, I'm part also of this screening group for the South, and really, the yield is very, very low. We'll have these screenings, and at best you'll pick up 1 or 2, and you've screened maybe 50 or 60 people, and it's not a high yield. So I think this Medicare screening is probably one of the best ways of approaching it. Only 50% of undergoing surgery for rupture AAA will survive greater than 30 days. The mortality rate for a rupture is about 80 to 90%. That number has probably decreased a little bit with stent grafting, but a lot of times it's not only that you repair the aneurysm, they've already come in by helicopter and extremis, and their kidneys die, renal function is bad, their lungs crash because then they get a lot of blood transfusion. You oftentimes, even if you do an endovascular approach, you still have to open their belly and decompress them because they get abdominal compartment syndrome. So it's a cascade of a lot of bad things, but definitely there is a clear decrease in mortality with endovascular repair of ruptured aneurysms. What's the pathophysiology? Essentially an inflammatory condition, and it's, I don't know that we know exactly why it happens. We have a lot of theories around what it happens, but it's a degradation of the extracellular matrix proteins, so the elastin, we talked about that, and the collagen. MMP9, I didn't put MMP2s there, which is also a critical part of it, and then some oxidative stress and autoimmune component also play a role. And then there is some evidence that chlamydia may have a role. So those of you who intend on going out and partying tonight, please keep it clean. But yeah, so it is, and there was actually a time where we looked at trying to treat with doxycycline to reduce aneurysms, and there's been some evidence that that may improve. We do see some aneurysms sometimes in AIDS, and that actually, if you can control the AIDS, it's been shown that you can actually control the aneurysm and shrink it to normal almost. We actually had a case here when I was at Baylor, and that's exactly what happened. It is an intimal disease, so AAAs are due to major medial damage. Risk factors for atherosclerosis, such as the things we all know about, diabetes, hyperlipidemia, hypertension is actually a big one, which is not there. And then, of course, a lot of those cytokines on the more biological level there. If you have a relative, particularly on the male side, who's had an aneurysm, 12 to 19% of first-degree relatives of patients with AAA will develop an aneurysm. So if you know somebody in your family that has an aneurysm, screening for you is probably warranted, independent of everything else. And then, of course, some genetic disorders like Marfan syndrome, Ehlers-Danlos, and I don't have Loeys-Dietz up there. That's also one of the ones that are big players. So age is a steady increase after the 6th decade. Family history, as I mentioned, male, 4 times higher incidence, cigarette smoking. Where is Chrissy? So greater than 90%, Chrissy, of AAA patients have reported smoking. Atherosclerosis and peripheral vascular disease, hypertension, hypercholesterolemia. AAA is less likely in African Americans than Asians. Asians actually have, particularly Japanese and Chinese, a much higher rate of aortic dissection. I went and gave some talks in Japan a couple years ago, and I had talks on all sorts of stuff, and the only thing they were interested in was dissections, how we manage dissections. But it's a big pathology over there. Diabetics are, the one good thing is they're maybe a little less likely to have aneurysms. So let's get back to cigarette smoking and AAAs. So for those who have never smoked and those who have smoked, don't put your head down. I know who you are. The majority of patients with AAA are asymptomatic. We talked about that. Symptoms that do show up, though, are back, chest, groin, testicular pain, buttock pain, and then, of course, if you have on palpation, they'll have abdominal pain for sure. So patients who have abdominal pain when you palpate them, that usually tells you that they're at higher risk for rupture. Although abdominal exam is not the most sensitive test. But if they come in with symptoms, generally we're going to operate on them. And although we say that aneurysms really exist above size 4 centimeters, and for men we usually operate when they're 5.5 centimeters, small aneurysms can rupture, and so small aneurysms that are symptomatic we operate on. Also, small aneurysms that expand quickly we operate on. AAA is associated with a lot of the disease that you guys also manage in the operating room, so coronary artery disease, male gender, smoking, COPD. So what's the long-term prognosis after repair of a AAA? According to the presence or absence of coronary artery disease. Well, kind of you can see that right there, right? So if they didn't have myocardial ischemia, they last pretty long. If they did, well, they die a lot quicker. And it says itself, right? If you go into an operation, you have pretty significant coronary artery disease, you're generally going to do less well. On the physical exam is basically a standard abdominal examination. Of course, if it's an aneurysm up in the chest, well, you're not really going to examine that well outside of a CAT scan or something of the sort. So AAA is palpable only a third of the time. So that's why I said an exam is not usually that sensitive. Of course, it depends on size, body habitus, and so on. So imaging is usually the way to go. And a good screening tool is actually an ultrasound. You can just put an ultrasound in the belly, and you can see whether there is an aneurysm. It's not always you can define it well, and so if you have an aneurysm, oftentimes if we go for planning, as we'll talk about later, planning is so important. That's the part you guys don't see us do. We spend, particularly for complicated cases, we'll spend hours planning and talking about which devices and so on. You have to remember a lot of the stuff that we do, so there's always an evolution in technology. And a lot of devices that we use are devices that have been developed based on us either modifying existing tools or talking to companies about, well, it'd be good if there were something that could do this, and we kind of work with companies to develop tools. Usually in the epigastric sort of mid-abdomen area, so usually the aorta is just to the left of the belly button. Deep manipulation, you can sometimes on thin patients, you can actually pick up the aneurysm in your hands and hold it. And then iliac artery aneurysms, they're a little deeper in the pelvis, are usually difficult to palpate. When they're symptomatic, usually that pain radiates down into the groin. Popliteal and femoral artery aneurysms, femoral are pretty uncommon, but if you have a popliteal aneurysm, that's actually a board exam for us, and I know somebody who was asked that question and forgot to say that you need to check for AAAs. 14% of AAA patients have popliteal or femoral aneurysms, so it's pretty important. And usually the way they give it to us on the board exam is they'll have you treat the popliteal aneurysm, and then you say, okay, everything's great. You send the patient to the floor, and then they say they call you from the floor, and the patient's crashing. And of course, they're dying from an abdominal aortic aneurysm. So prominent pulses. So generally, popliteal aneurysm even less detected than aortic aneurysms. Usually, the way you find those is people come in with a cold leg. So they either shower, clot down the leg, or they just clot off. So that's really kind of a pretty crappy deal, actually. So 62% of chance of AAA with popliteal aneurysms, and 85% chance of AAA with femoral artery aneurysms. So pretty good link there. And you can see kind of here just how you can size up with an ultrasound image. I told you about that already. So essentially that the screening 65 to 75 years of age, it's an invitation for AAA screen, which is associated with a significant reduction in AAA mortality, 43%. Low risk routine screening, that's really the ultrasound screening. But we have recommended against screening women. And actually that's not only in the US, so don't feel that you're singled out women. It's actually also in Europe. It's just a benefit versus cost thing. So there's kind of a sustained benefit of screening men, and you can see that over time in the invited group versus the control group. So interval for follow-up, if you have an aneurysm of a certain size, less than 3 centimeters, obviously no further testing. 3 to 4 centimeters every 12 months, 4 to 4.5 centimeters every 6 months, and greater than 4.5 centimeters, you consider for referral to a vascular surgeon or whoever else is going to treat it. Now, one of the things that we always talk about is patients come to us and they have a 4.5 centimeter aneurysm, they're 50 years old, and they you tell them you have this, it's pretty, you don't have to operate on it now. You can come back, we'll follow you up. And a lot of patients actually don't deal with that so well. They have a significant problem in their belly, and a lot of them lose sleep over it, and they'll come to you and they're like, can't deal with it, you got to get it done. And that's fair enough. I think it's obviously something that would bother most of us, particularly when you're young. If you're 89 years old and you have a 4.5 centimeter aneurysm, in your lifetime, the likelihood that's going to need to be operated on is pretty small. But if you're 50 years old, clearly in your lifetime, you're probably going to have that operated on. So a lot of people would rather have that operated on earlier. And there is a push from our societies, at least, to try and maybe push the age, or bring the age down a little bit for treatment. So ultrasound is really an excellent excellent tool for diagnosis and sizing. It's also excellent for follow-up. So basically, just looking at aneurysm growth. It's non-invasive. It's low cost. A lot of our patients have renal insufficiency, so you give them dye. It's a problem. Of course, you can do an MRI and so on, but generally, an ultrasound is all you need. And for the most part, actually, even after treatment with a stent, because those are the only ones that you follow up for a long period of time, we used to actually do CAT scans. So imagine what a CAT scan, how that can influence not only cost, but exposure radiation to a patient, contrast, and so on. Over a period of time, now we've gone away from doing CAT scans for everything. Generally, at least what I do is I do one CAT scan when they come back to make sure everything is good. And then after that, all they get is an ultrasound for the rest of their time. And we do follow them up for forever because we know that stents, I'll show you some of that data in a little bit, but stents do require some tinkering with over time. Not always, but in a fair percentage of them, about 10 to 12%. So a CT scan is indicated only for treatment planning or when duplex is not good enough. The goals of treatment seem pretty evident, right? Prevent rupture. That is a rupture. That's what a rupture would look like. All that stranding, all that fluid that's around there, that's all blood. And of course, prevent death. Diagnosis of rupture is usually clinical, so pain or hypotension. We had one patient recently who was sitting in ER for about 12 hours, thinking they had kidney stones, being treated for kidney stones. Pain got worse, and lo and behold, there was a iliac rupture. Who did that with me the other day? No, nobody. Yeah, one of you in here at least. I know I didn't do it by myself. So factors associated with increased rupture of AAAs is smoking. So gender, women actually tend to rupture a little bit more. Hypertension, COPD, and most important predictors, the size of AAA. So you look at kind of there's kind of an exponential increase in rupture risk as you increase in size. So obviously as you get up to around the 6 centimeter size, a 10% risk per year, and so on down the way. Annual growth rate is approximately 4 millimeters per year. And one of the largest trials to look at aneurysm growth and rupture is actually this UK small aneurysms trial, where they looked at a little over 1,000 patients with AAA, 4 centimeters to 5.5 centimeters. The mean risk for rupture increased from 1.6% initially to 3.2% during the last 3 years of that trial. I'm going to go through some of this a little quickly. So, how do we measure these? It actually differs depending on what you're going to do. So different devices, so when you measure an aorta for shear size, we usually go kind of lumen to lumen. Sometimes there's thrombus, so you want to go out at least to the outer wall. But if you're measuring for an endograft, it changes a little bit because each device is configured a little bit differently, and so you want to measure either outer wall to inner wall. Remember, we always look at these static images, but the reality is the aorta, just like every other organ in our body, is very dynamic. And so we talk about, you guys have seen us do some coiling of these aneurysms, and that's because there is a distensibility to the aorta, and we get these leaks sometimes. And sometimes the leaks are because either it's not sized properly, or maybe the neck has distended a little bit over time. Some people say that it's the radial force of the stent that'll cause that over time. Reality is we don't really know. The guidelines for treatment are basically mandated by all our surgical societies, and we try to keep that to kind of stick to that as best as possible. Measurements are by minor axis, so AAA should be treated when greater than 5 centimeters in women, actually, and 5.5 centimeters in men. Women should have their AAAs repaired at a smaller size than men, and that's because of the higher rupture risk. You can see here the baseline variable that predicts for rupture more is actually female sex is one of them. Size of AAA rupture in women, 24% less than 5.5 this is from Finland, and 76% in greater than 5.5 centimeters. So we are a little more vigilant, but still not screening. There are more gender differences in hospital mortality. So if you look at women tend to die a lot more from even elective AAAs. So what are the treatment options? So all patients get medical optimization. Remember I spoke about early on that there is a strong association with coronary artery disease and other pathologies like peripheral vascular disease and so on. So they all need their vascular disease managed. And that's something actually we didn't always know. Seems intuitive to most, but it wasn't something we always knew. There was actually a guy by the name of Hertzer out of Cleveland Clinic who was a vascular surgeon some years ago. He decided he was going to do coronary angiograms on all patients coming in for vascular disease, including AAA. And so he took 1,000 patients, and essentially what he found is that a third of them had actually treatable coronary artery disease, or not treatable, disease that actually was severe enough that it mandated treatment. The open repair depends. Here I write direct access via the abdomen, but that really depends on whether it truly is a infrarenal aneurysm, which means that you have enough neck or enough normal aorta between the kidneys or the renal arteries and the actual aneurysm. And if it has, it can be a juxtarenal so that the aneurysm actually goes all the way up to the origin of the renal arteries, although it doesn't include the renal arteries. And there are multiple options. Of course, endovasculars, I think even for myself, if I were to have one of these, I'd prefer to have an endovascular option, which we do obviously via the femoral arteries. Preoperative CT scan is essential. The goal of optimization, as far as medical optimization, is to decrease the likelihood of people smoking, treat their hypertension, the hypercholesterolemia, and then beta blockers has always kind of been the drug has been shown to at least reduce mortality associated with vascular surgery. That's actually been refuted now. It was found that actually the guys who created the initial trial out of Holland had falsified their data. I think Austin Powers was right when he said, he hates, what was he, how did he say it? He hate everybody? No, I don't know, I forget it. Anyway, I feel like George Bush all of a sudden. So prepare for a patient for operative procedure. You will usually at least get a cardiac screening, make sure that their coronaries aren't diseased enough that they require treatment before surgery. And then, I know we always do our timeouts. We check for beta blockers. It's actually not protective in vascular patients. It is protective in cardiac patients, though. So that's something we check, but probably not a necessary thing. Statins, for those of you who know what they are, they're not triglyceride, but cholesterol medications. They also do decrease your triglycerides, but they more than anything else have a positive effect on your intima, and they protect against coronary events, they protect against cerebral events, and so on. And so most of our patients we have on statins. When I was in Denmark doing my research fellowship, I started doing some of the first trials on statin therapy in vascular patients, and the benefits were so huge that we actually, in the department, we started taking the study drug. We had like boxes of study drugs that were left behind after the studies were done, and we just started popping them like they were vitamins. I've since then stopped doing that, but anyway, I pop other things now. So I said earlier that there is some evidence that antibiotics can reduce or protect against aneurysm growth. Not enough that you would say that should be something you treat primarily with. Technically, all AAAs can undergo open repair. We're limited mostly by cardiac disease. If they have bad coronary artery disease, bad valves, whatever else, then you want to try and avoid an open repair. Today, probably we avoid open repairs as much as possible. The devices, we started doing this back in 1992, and we're through multiple generations of devices, and they've just gotten so good that we think they last pretty much forever now. Not all devices, but the main device that you guys are used to working with, the Gore, the Cook, the Medtronic devices, they're kind of the solid devices that'll last a good while. And then of course we try and manage their pulmonary disease if we're going to do something open. Again, if they have bad disease, we can even do these under local if we're doing endovascular. Somebody who's had previous operations, colostomy, multiple procedures, I remember a case I did when I was in New York, and it was a guy who had multiple abdominal operations, and it was really before we were really good at endovascular. There weren't that many people that were doing it, and we just could never get into do enough lysis adhesions to get down to the aorta, and we abandoned, and the guy a few years later ended up rupturing actually and dying from his aneurysm. Difficult anatomies, you can have inflammatory aneurysms, so some of them are infected. Those you generally want to do open because you want to debride all that, but sometimes what we'll do is we'll put a stent in to kind of get the inflammation to subside a little bit, knowing that we're going to come back and excise that and go and repair this with a open approach. And then of course some systemic diseases it would be preferable to do it endovascularly. So what are the results of open versus endo? So for one, if you use open, there's a greater use of ICU, increased 30-day mortality, increased length of stay, increased postoperative pain, that seems pretty evident, and then fewer subsequent aneurysm-related procedures. You guys have seen all this, what that looks like, open versus endo. That was the same slide. So endovascular repair, up there, I said, can only be used for suitable anatomy. And that's true, although you guys have certainly seen us do things that didn't have suitable anatomy when patients weren't suited for an open operation. Sometimes I would say, how far do you push the envelope? Because like anything else, we use a lot of our products off-label. We always inform the patients that we're using these things off-label, and I think it's important that you do that. But you're essentially limited by the devices available in the market. In the US, we're limited primarily by the FDA. So if you go outside of the US, and I'll show you some of the devices that are available outside of the US, there are a lot more options available. And it's not because they're bad options, they're just not studied in the US, they're studied overseas. And so, until it's studied here in the US, the FDA won't allow them to come in here. Unfortunately, because the cost of studies, doing these studies is so high, some of the companies never intend on bringing these devices here, and some of these we'll never ever see. But in essence, from an endovascular repair, you're limited by a short proximal neck. So if we're just talking about infrarenal aneurysms, then we're, by disease landing zones, what that means is if you have severe calcification because you can't anchor the device, or you have a lot of thrombus, because of course the device is going to tend to slip because it's only anchored into clot. Aneurysmal necks, severe angulations, although there's a device on the market for 90-degree neck angulations, but not a huge supporter of that device. And then, of course, if you have access problems, that used to be primarily in women. So if you have small iliac arteries, very diseased iliac arteries, but we find usually ways around that. And we used to do a lot more conduits. If you guys remember, we used to do retroperitoneal exposures, and so Dacron conduits onto the iliacs and then pass the devices up that way. We do that less and less. Also because the devices, the catheters that we deliver devices with have gotten a lot smaller. The advantages to an endovascular repair, local or regional anesthesia you can use, lower in-hospital mortality, lower 30-day mortality rate. The complications, and so these are the things that bring patients back. So we talked about endoleaks, increased reintervention rates, metal fatigue, and fabric wear and tear. Thankfully, that happens fairly rarely today. There are some older stents that have been implanted years ago that are still in the market, and we see some of those come back and have to either fix them open and remove them, or we kind of put a new device in and extend the old device. But lifelong surveillance is important. But I think contrary to what we used to do, like I said earlier, we don't do CTs anymore for all our patients. We do ultrasound primarily. This is what a endoleak looks like. If it's this is what's called a type 2 endoleak, and we'll usually try and come into the sac here, put coils or glue. You guys have seen us put onyx in there, which is a compound like a glue almost, to try and close off those vessels that are prior. These are spinal vessels, so you remember if they have flow through the aorta, normally it flows out to the spine. In this case, because the majority of the flow is going through the stent graft, the flow is now retrograde into the sac. And really, you can have a type 2 endoleak and it never impact. If the aneurysm doesn't grow, we leave it alone. We don't treat it because it's there. And we'll sometimes do at the end of a case, when we do our completion, you'll see a type 2 endoleak, and we dictate that in our note and say, well, we'll just watch the aneurysm and see if there's any growth. And like I said, we put coils in there to try and close those things off. Let me go through some of this stuff real quick. So if you look at aneurysm-related mortality for the EVAR group, and this is still the UK EVAR trial, essentially you can see in the upper two curves for open and endo repair, it's actually fairly small. All-cause mortality for EVAR and open repair, a little bit higher, of course, but fairly equivalent if you look at it. Overall, if you look at, this is a trial from Holland, essentially you can see that endovascular repair has a better survival than does open repair. Now that survival benefit, though, goes away at about 2 years, where then the two kind of line up and then continue along the same path. So elective open repair versus EVAR, and you can see here open mortality, and that's of course as you go up in years, the mortality rate is a lot higher, and that's why we prefer in the older group to treat them endovascularly. Should we treat small aneurysm? I told you basically a lot of them, particularly if they're up in the years, will probably never need any treatment. But some of them obviously will, particularly the younger patients. So those are the ones we tend to treat a little faster. And if you look at randomization to early elective open versus surveillance, really no advantage to early surgery for at least 4 years through 12 years. And you can see that in that curve there on your right-hand side. I'm going to go through some of the devices now, and then you'll be rid of me. So we talk about fenestrated devices, those are the ones you guys have seen. You have not seen branch devices. Branch devices means exactly what it says. There's actually a branch coming off the stent graft. And then there's a lot of limitations to the current stent grafts. We've talked about the fucking robot, which is right here. That was really when they first launched it, they were hoping that it was going to help actually some of these fenestrated stent grafts. Proved not really to be as valuable as all that. There are a lot of other grafts available, and of course, grafts of the future. Technical success for fenestrated stent grafts is up to 97%, so pretty successful. 30-day mortality is 3%. Although, you know, a little caveat there is there's really one vessel that can sort of kill a whole procedure. So it's 3% if you're doing fenestrated stent grafts to the renal arteries alone. If you're then including the SMA, if you have a problem with the SMA, and most of our mortalities here have all been related to SMA-related issues. Usually they're embolization to the SMA, and those are almost unrecoverable. The only fenestrated stent graft available in the US today as a non-study product is actually the Cook, which is also the only one we do here. The Anaconda is a kind of neat device that's only available in Europe, and what's neat about it is it's repositionable. The Cook, once you deploy it, that's it. It stays where it is, and sometimes we're not so happy with where we deploy it. So I'm just going to go quickly through how this stent graft is constructed. It's essentially, it's the same thing as the Zenith infrarenal device for Cook, except for it has fenestrations. These are created based on all the planning that we do ahead of time. So we get the CAT scan. We start drawing some lines and so on, and they have like a chart that I'm going to show you in a second on how we draw those up. And then we send that over to Australia, and they build this whole thing by hand and then send it back to us. They put all these different markers on because we need to know where the fenestrations are. As you can see right here, we need to know where the different locations, how we need to turn it to orient it properly. Sometimes you'll have what's called a scallop, which is what you see here. Usually that's for the SMA, sometimes for the celiac if you have 3 fenestrations. And then this is kind of what it looks like. We do everything based on actually the guy I was telling you about who died from abdominal cancer, he actually came up with this whole concept of how you measure up for a fenestrated device, but it's actually based off of a clock, and so that's how we draw it out on the form. The form looks like this, pretty much still today, and then this is what we send off to Australia. So the indications for the stent graft is really for juxtarenal aneurysms, so aneurysms that have no neck below the renal arteries, or short neck landing zones, so less than 4 millimeters. And then one of the limitations, like most stent grafts, is you can't have high angulations. So usually these are in multiple components. Here you can actually see that there is already a stent graft up higher, and we come in all these little gold markers, or these markers you see as black are the gold markers I showed you before. Those are the ones that we use to kind of know where our fenestrations are, where our scallops are, and kind of know what the orientation is supposed to be. These 3 lines right here down the middle tell you about orientation. So if you guys have noticed what we do before we put it in the patient, we actually put it under the Flora unit on top of the patient. We kind of rotate it back and forth. And that tells us whether we have it oriented properly. Ultimately, if you go back here, you can see what we need to do is get our sheaths, our wires, well buried through the fenestrations into the appropriate vessels, and then prepare for our stents that are going to go into those vessels and eventually treat the aneurysm so you hopefully get something that looks like this, with a good result. This is actually a branch up here, not a fenestration. That we don't have here in the US, so that's not available to us at all. One of the limitations, of course, is the time to manufacture now. 6 weeks. We really have been pretty good lately about getting it down to 2 to 4 weeks. But obviously, it's not an off-the-shelf, so if you have somebody who comes in with a symptomatic aneurysm, non-ruptured, you're not going to be able to use this device. The goal has always been to get off-the-shelf devices so that patient comes in with a problem, you can treat it then and there, but that's not a reality today. Fenestrations have to be at least 2 hours apart on that clock face I was showing you earlier. You can't have any significant renal stenosis, although we've kind of been a little more lax with that. And then distal iliac landing zone of at least 30 millimeters, and of course the cost is pretty significant. When we talk about cost real quick, I think a lot of the proponents of open surgery always talk about cost of devices. The reality is cost of a thoracoabdominal aneurysm is not insignificant, right? Longer hospital times, we talked about long sniff times, trachs, so ventilator, all these things that really also add significant amounts to the cost. If you can get patients, I think, through an operation like a fenestrated device easily and quickly, they do a lot better, and obviously the cost of the device is offset by the decreased length of stay and all the other costs associated with it. This is a device that's actually going to be in trial here in the US. A few sites are already using it as a trial. It's been used in South America a fair amount. This is a device by Gore. Most of you are familiar with the Gore devices. I'm pretty excited about this device. One of the things that those of you who've seen us do fenestrated stent grafts is it's very hard to get, you imagine you're working kind of at 90-degree angles, sometimes even worse angles, getting into vessels. Here they actually have gates. So let me see yeah, so you probably see it easier over here. But the device actually has gates. So they're actually inside the stent graft, the main part of the aortic stent graft. So you don't have to go at 90 degrees to get in. You just go straight down into the gate and get into the vessel, which is much easier than what we're doing today. So this is a device that will be coming around in the future. It exists. I've seen it and played with it. It's a pretty easy device to work with, actually. The Anaconda is the device I was telling you about that's in Europe. It too has fenestrations. Again, the advantage is that it's repositionable. You can collapse it, just like you can the current EVAR device or endovascular aneurysm device for infrarenal aneurysms by Gore. This is called a C3. It's also repositionable. It's got a flexible main body, closer fenestrations, and all the cannulations of the branches happen through brachial access. Essentially, you got the top is a dual ring, high radial force, and it's got hooks just like most devices. You kind of see here how it's constructed. And there's standard 2 fenestrations, and you have kind of this whole concept of there's a device here in the US that has the same concept. It's got these cradles. So what they want you to do is orient it properly so that when you construct it, the SMA would, for example, go in that cradle. It's the equivalent to, for example, the scallop that I was showing you before on the Cook device. But that's essentially what it looks like when it's deployed. So very much same concept as you have for the Cook device. I've never used this device, but I don't know. I would assume that a lot of this wiring would seem to be pretty confusing. As far as seeing exactly what you're putting in and seeing your wires and everything else. Now you have obviously the branch devices that I was telling you about before. There are, I think, 3 centers here that have branch devices, and they're on physician-sponsored IDEs. That means you write your own IDE, and then, in this case, Cook may be inclined to have you as one of their investigators, and they'll allow you to use their device, and then you can really modify it any way you want. and have a device that really fits your patient's anatomy with more options. We also have iliac branch devices. This is Cook's, kind of looks like this. This is actually the Gore device, and we did the first one in Houston right here. Actually, I did it with, I don't know, somebody. Let's see if this, yeah. So this is how it works. It's pretty simple. And this is actually based on techniques we used to use before. What makes this easier is we can now do everything from the groins. We used to do part of this procedure when we used to do it with the existing grafts, modified grafts. We used to do part of it from the arm, which for those of you who know, when we're working from the left arm and the groins, it's kind of troublesome. You need 2 tables, so 1 table on each side, and oftentimes 2 scrubs, and it's just a hassle. So this actually makes it pretty easy. So here what you see is essentially a sheath coming over, which deploys the initial device. What you can note there is actually it deploys at the bifurcation. And then essentially you're going to come through a wire that you've already snared up and over, and then you're going to treat into the internal iliac here. Why do we try and preserve internal iliacs? Well, because patients have complications when you don't. We used to embolize a lot more internal iliacs and stage them. So they'd come in, you'd coil it, you'd block it off, and then you'd come back and you'd do an EVAR. And a lot of them get buttock claudication, which doesn't always go away. And then some of them just have a variety of issues associated with occluded pelvic circulation. Then eventually you're going to come in, now you're going to just do a standard EVAR at this point. And you guys know obviously how that happens. You go up here, you'd have a neck up here. It's a standard Gore EVAR device at this point. And then you bridge the 2 here with a separate device. It's actually pretty neat device and fairly easy to use actually. So here you come and you'll bridge right here and be done. So the challenge of FEVAR, so stenotic origin of visceral arteries, that's sometimes pretty challenging to get in. You can have acute angles of the viscerals, so again, hard to get in with a combination of different catheters we use. And that's really where we thought the robot would have a huge application. And then oftentimes we're trying to combine, or there's challenges with the combination of the 2. And then the additional challenges of tortuous iliac arteries, sometimes small iliac arteries. So when you have your large sheaths in there, you're actually occluding flow to the legs. So sometimes you'll see us modify the sheaths so that at least you get some pelvic circulation, which will give some collateral circulation to the legs. I know Dr. Bashar had at least on one case where he thought there was enough flow to the legs and there wasn't, and the patient ended up having a cold leg afterwards and a variety of issues associated with that. So we'll cut the sheath sometimes to make sure that there's enough flow down to the legs. Then we talked again here about the steerable catheters. We do some back table here. Actually, Methodist doesn't allow us to do it, but Dr. Bashar used to do it over at the VA, and there's a number of places around the country that do it. Essentially, you deploy the stent graft on the back table, and then you do your modifications. So you'll sew your own, you'll see it here. You'll sew your own gold rings in. And then so either you cut a piece of a little stent graft off, or you can sew some Dacron on or something like that, and then create something on the back table and resheath it, so put it into another sheath and then deploy it in the. That's really trying to get around the limitations of what we have on the market here in the U.S. So in situ fenestrations, I'm proud to know that I've done the only one in the world actually, right here. So I'll go through that one real quick. So this was actually a C3 excluder, which is a repositionable device, and I really thought this was actually the way to do it. So what we did here was, it's actually interesting. The only reason I knew about, I'm using actually a transeptal. So those of you from the cath lab, this is actually a transeptal device, which I just punctured through the stent graft with. I'd obviously done a lot of testing on animals and models in the lab before doing this. I'm not that much of a cowboy, but We did do this, and actually it went really well. So we wanted to get in, there was a large accessory renal that we wanted to save. And so once we punctured, we actually got our wire out into that vessel. The stent was then finally completely deployed. We used a cutting balloon to open up to essentially cut that PTFE that's on the stent graft. And then we deployed our renal stent. You can see there's a little bit of narrowing there where we're deploying our renal stent. This is an ICAS stent here. And so we just went in afterwards with a little bit high pressure balloon, and you can kind of see what that looks like after we completed our procedure. The guy, we've actually followed him up out. I think he's about 6 years out now, and this has held up really, really well. But that's also because of a limitation of what we had available to us. Coming soon, we will have off-the-shelf branch devices. That is the goal of at least Gore with their TAMBI device. And then current branched graft development is focused on the proximal thoracic aorta. So this is a device that we're part of as far as trials. You're going to see a little bit more of that in the future. So we're just finishing up all our paperwork for the IRB to be part of the trial for this being deployed into the brachiocephalic or into the left subclavian. So those of you who will be in the ER with us will see this. This is a device that I worked on for a little while. It's now defunct, but it was actually a kind of neat device for the thoracic aorta. This is actually in a pig, but the device actually would have 3 branches that you could use into each. They're preloaded, and they would be used at each one of the supraortic trunks. As you bring it up, it's pre-wired, and you'd get wires into those 3 and move it into the right position. You could accordion it to lengthen or shorten it as you needed to. The company just ran out of money, and so it died, unfortunately. But they also had kind of an off-the-shelf device for the belly. So I think in summary, current devices we know can be costly and require standard manufacturing time. With time, if these become off-the-shelf devices, we think costs will come down significantly. And of course, that'll be easier to have less of the current time constraints to have them constructed. Hopefully, we don't need to push the limits of the current technology, but that's our reality right now. And probably in the US, that'll remain the reality for a while. Like I said, we have current developments which are aimed at thoracic branch grafts. Ultimately, I guess the goal is really to have a total endovascular solution, basically from the valve all the way down. We have 2 TAVR days a week here. We're one of the busiest TAVR hospitals in the world, I think. And so, that technology definitely has progressed quite a bit, and I know they're doing a lot better than they used to. But everything is moving in the right direction for patients to do better, to have less complications associated with open surgery. But this is not perfect technology by any stretch. And so, I think the day when we get to off-the-shelf technology overall, we'll be in good shape. Okay, thank you. Yeah. Yeah. Untreated we're talking about. So what we do is, so if you follow them up in 12 months and you repeat a scan, if there's been more than the 0.4 or 0.5 centimeters in growth, then we'll follow them up closer the next time. So it's not like we see them, they come back at 3.9, and then we just give them another 12 months. We'll see them maybe even in 3 months. Yeah.
I have a question.
Yeah.
Given the more complex procedures that we're doing and these more complex interventions, can you provide some discussion or thought about a briefing before the procedure so that we have a better understanding as to what your plan is so that we can anticipate for you a little better?
Yeah, I mean, so that's actually a very good point. So, because if you look at the way they do TAVRs, right, there's an exhaustive briefing, not only in the OR, there's an exhaustive briefing and talk about the cases before you even get to the OR. Now, we have that talk, but mainly it's between the faculty and the rep. I usually try and brief with all the residents, but you're right, I mean, the nurses should probably be included in that because there are a lot of moving parts. And coordinating that, a lot of times I think can reduce the OR time, can reduce frustrations on all parts. So yeah, no, absolutely, I think that's a really good point. And probably I think, what should really happen should be team training around that. So how, I think one of the issues with that today is, so if I look at my colleagues around the country, they're usually dedicated vascular nurses. So they're more dedicated or more in tune with what the actual processes are around these devices, both complex and simple. And I think that really I've always thought that would be the way to go. Have somebody who's really, kind of burns for it, and have a core group of people. Of course, there's going to be some cross-training and so on, but I think having a core group is really one of the ways to go with it.
Any other questions about this topic? Thank you so much.
Well, thanks for having me.
Today.